stop yourself. You know, there's always hurdles, there's always challenges. Just keep going. Don't bother what other people think, what other people say. So that's what's going to help you to achieve things in life. So and I thank the organizers in the usual manner, and I thank Professor Arifin for inviting me here today. She's my batchmate, and I got a call from her almost after 25 years. I was surprised, but I couldn't refuse it. But anyway, I did study at Tajul Medical College, so it's quite beautiful. So I've been asked to speak about not just Ataxia, expanding landscape of cerebral movement disorders. Frankly speaking, I never knew the importance of physiology. This is to be very frank. We call the spade a spade. When I left MBBS and I did my pediatrics, I forgot physiology. I never looked back at physiology until I did my neurology and my pediatric neurology and my movement disorders. That's when I realized everything falls back to physiology, anatomy, and biochemistry. So it starts from physiology for you to know and understand pathophysiology, and only then can you analyze the neurology and treat the disease. So my introduction is just run through this. Just one small mention in this introduction is, we're speaking about cerebellar diseases, you must remember there's a vast difference between movement disorders and disorder of movements. Since I'm one of those who do much movement disorders, I probably will try to use my time to illustrate slightly further. If not confuse you, but either way you learn something out of it. Now, when you speak about movement disorders, you're speaking about a distinct phenomenology, and which falls back to emphasis on clinical history and the evolving understanding of genomics, proteomics, and molecular biology. So movement disorders are distinctly divided into hypokinetic and hyperkinetic. However, you have disorders of movement which are not clearly included under the umbrella of movement disorders, which include spasticity, ataxia, and some form of bradykinesia-like movement, which are not bradykinesia. So these are called as disorders of movement. Okay, so focusing on cerebellar diseases, the landscape is such that, the evolution is such that you're looking at conditions which may present as movement disorders, hypokinetic and hyperkinetic, which are cerebral in origin, or at the same time looking at conditions which are not movement disorders but disorders of movement. So, can I have volume for this? I think this is a fine 2 minutes lecture. Can I have volume? This is a fine 2 minutes lecture from neuroscience, and I think it has done so much more better job than what I can actually do to describe the physiology and anatomy and neurology of the cerebellum.
Where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the cerebellum. Cerebellum is Latin for little brain. The cerebellum does look like a miniature version of the brain as it protrudes from under the posterior and inferior region of the cerebral cortex. Although the cerebellum has many functions, it is primarily associated with movement. Specifically, it seems to be involved with facilitating movement by detecting errors that occur in the course of the movement and correcting them, so the movement appears fluid and achieves its intended goal. The cerebellum is also involved with motor learning to reduce the likelihood errors in movement will occur again in the future. The cerebellum consists of 2 cerebellar hemispheres and can be divided into 3 parts. The cerebrocerebellum receives input from the cerebral cortex and is involved with planning and initiating movements. The spinal cerebellum receives information about limb position and touch and pressure sensations from the spinal cord. The spinal cerebellum uses this information, for example, to compare where a limb is in space with where it should be if movement were going as planned. If there is a discrepancy, the spinal cerebellum can modify motor signals to correct any errors in the movement. The vermis is the area of the spinal cerebellum that runs along the midline of the cerebellum. It is involved with posture, limb movement, and eye movements. The vestibulocerebellum, also called the flocculonodular lobe, is important to maintain equilibrium, balance, and posture. The cerebellum communicates with the rest of the nervous system through 3 large pathways called the cerebellar peduncles, which could include the superior, middle, and inferior cerebellar peduncles. When information is sent to the cerebellum, it takes an indirect path to reach extensively branched cells called Purkinje cells. These cells then project to a group of nuclei in the center of the cerebellum called the deep cerebellar nuclei. The deep cerebellar nuclei send the information to various areas in the brainstem and thalamus that then can influence motor areas of the cortex or descending motor tracts to modify movements.
Thank you for your patience. There's a beautiful 2-minute lecture on anatomy and physiology.
Or I synthesis, please.
Cerebellum. So, cerebellum basically plays a key role in any form of motor control. And it has a significant role in any form of movement disorders or disorders of movement. So damage to cerebellum will either lead to movement disorders, and why I'll explain later, or any form of disorders of movement. So movement disorders consist of tremor, dystonia, myoclonus, and disorders of movement will actually constitute ataxia, bradykinesia, and so forth, and imbalance in coordination. So as it's already been mentioned that, that's got a unique anatomical and physiological attribute, that's cerebellum. Although it's so much more smaller than cerebral cortex, it has got anatomical and physiological attributes which are almost close to the cerebral cortex. It's got 10 different lobules, and the structure is very important in maintaining the precision of movement. Despite the motor cortex giving information out through the nigrostriatal pathway into the cerebellum, cerebellum plays a significant probably towards the end node and trying to fine-tuning the movement that we are intending to. So now how cerebellum modulates the voluntary movements and why the dysfunction has occurred. Basically this occurs through millions of function connection with other parts of the brain, especially the motor cortex, upper motor neurons, as well as the nigrostriatal thalamic and cortical pathway. So it is involved in this highly integrated network which involves the cortex, brainstem, and spinal cord. Now, I'll just skip this slide since now how does cerebellum modulates the movement? So you have this information from the upper motor neuron, the cortex, and which comes to the cerebellum, and from there it evokes afferent cells which do not go straight to the brain, do not go straight to the cerebral cortex, but actually project to the brainstem and also spinal cord and to the aspects of function of low motor neuron. And instead of what you call controlling the basal ganglia, it kind of says, hello basal ganglia, I'm here and I've received some information, so just have a look. So then the projections go into the deeper nuclei of the cerebellum and slightly to the upper motor neuron, which are the cortex. And from there, the afferent pathways slightly budge to the cortex, at the same time giving information to the cerebellum, which are the deeper nuclei of the cerebellum. Look, I've sent some information to the cortex, let's see what they say. And with this network, you get this synthesis of fine-tuned, smooth movement, of which cerebellum plays a huge major role. Now, so to put it in a very much more simplified, more simple, kind of nutshell, it differentiates and fine-tunes the movement between what you intend and what are the actual movements. Because intention may not be translated to actual movement if the nigrostriatal pathway and cortico-nigrostriatal thalamic and cerebellar pathway is dysfunctional. So, the primary physiology of cerebellum and movement, coordination, it functions as a comparator between the intended movement and also the actual movement, and makes real-time micro-milli-nanosecond adjustments in the movement that has been intended, that has been planned by the cortex. The volitional cortex sends information to nigrostriatal pathway, comes to cerebellum, and cerebellum says, okay, this is how we should do the movement. Now, of course, balance and posture, which is probably the most infamous function or known infamous function of the cerebellum through the vestibular cerebellum. And muscle tone, this is something that is usually not known or not recognized as a function of cerebellum because it does regulate the muscle tone. So this is what clinicians, neurologists see, where patients come in with cerebellar disease, whichever pathology it might be, they have got this element of hypotonia. So although hypotonia has always been a function of low motor neuron, that means the peripheral nerves, the muscular and the neuromuscular junction, but bear in mind, as I just mentioned, that cerebellum does play a role, does project to the higher functions, the basal side, the nigrostriatal pathway, and also the lower motor neuron function. So with the dysfunction of cerebellum, it is not surprising to realize that hypotonia can be a clinical finding in cerebral disease. And motorally, something that we rarely read, but it is mentioned in Guyton, because I went back to look at Guyton and I realized one of the newer editions, not my edition, but a newer edition is Guyton 2005-2006, did mention that cerebellum has got some function motorally. So it kind of refines the movement as you repeat the movements and you repeat the function. So this kind of goes well aligned with the old adage, practice makes perfect. So it is not something that people just mention out of the sky, but because cerebellum actually functions to do that. And of course, the function of cerebellum in what you call fine-tuning, coordinating, and planning the eye movement. So when you expand the spectrum of movement disorders and disorders of movement, with regards to cerebellar disease, you're looking at ataxia. Everybody knows that. Dystonia, which is a repetitive, repetitive and abnormal movements and posture, secondary to co-contraction of the agonist and antagonistic muscle. Tremor, rhythmic oscillatory movement around the joint because of the agonist and agonist are sequentially functioning. And of course, the function and also the control in regulating speech and oculomotor function. Now, first, before we move further, neurology, movement disorders of cerebellar disease. Nystagmus, everybody knows, and cerebellar disease is infamous for nystagmus eye movement, but one of the most important things to remember how to differentiate between a cerebellar disease nystagmus eye movement and the vestibulopathie induced eye movements. It has got certain amount of control of this impairment in impairment in the pursuit, smoothness eye movements. Hint exam, which consists of 3 head impulse, nystagmus eye movement and skew test, and scanning speech, which is something very clearly seen where a person who has got cerebellar disease of any pathology tends to choose the word, and we call it staccato speech. They speak slowly as though they're trying to find the words. It's not a word finding difficulty, but it's more of coordinating the words that your brain has already emanated or released. Hypotonia, as I already mentioned, and cerebellar mutism, which people rarely recognize, but neurosurgeons are very familiar with it because when they do neurosurgery, when they do surgery for medulloblastoma or any form of glioma around the posterior fossa, they always see that patients become mute for a few more months or few weeks if it is being listed as cerebellar bonis. And other neurological signs are dyspepsia, which is examined by finger nose, dysdiadochokinesia, inability to conduct repetitive alternating movement, rebound phenomena, something that we should examine but has been forgotten, and it's mentioned very clearly in Hutchinson clinical examination where a person is asked to put the hand or anywhere and there is a pressure against a certain movement. When you release the pressure, there's always a rebound and they can't control, and intentional tremor, which is infamous for cerebellar disease. Here's a chart to show these are the clinical signs to see movements and disorders of movement. I mean, the entire list technically represents some form of abnormal movement or some form of disorders in movement that we see as a result of cerebellar disease, and it is manifested clinically and interpreted in a certain manner. For example, ataxia. I'll show a few videos later that. It's the inability to maintain posture, maintain balance, respective vestibulopathies. Now, decomposition of movement is something so obvious in cerebellar but very poorly recognized. And we take it for granted in the sense that when you plan a voluntary movement, when I plan to hold this mouse and function the mouse and rotate the mouse, it is so smooth and I take it for granted. But cerebellar plays a huge role in trying to compose these movements rather than being a decomposed, fragmented, multiple movements. Dysarthria, dysdiadochokinesia, dysmorphia common, hypotonia, muscle tone, and the rest are quite common clinical signs. Now, how do you look for the clinical signs and how do you interpret the clinical signs of cerebellar disorder, the disorders of movement, the movement disorders? You may not be able to look at a child and say, look, this child has got a cerebellar disorder, and then the clinical sign as a result of ataxia, as a result of loss of what you call posture and balance, or this is secondary to hypotonia. But you need to crack the code. You need to crack the code in the sense that take it from ABC, take it from the top, and clinically examine the child and synthesize in a more organized manner. So almost all patients, especially those cerebellar wormies, because it's what you call more vestibular cell involved, they have got certain form of gait disturbance, ataxia, imbalance. Speech disturbance are common in bilateral damage, but not very common, obvious in unilateral damage. However, you need to look at cerebellum in a more holistic manner, in a such that you may not have lesions in the cerebellum, but because of the dysfunction of the tract that I've mentioned, I've introduced from the very beginning, you may see cerebellar signs in patients who have dysfunction of the network, disturbance of the network, or impairment of the network, but not a cerebellar disease itself. This is a concept that is kind of proving, kind of gaining some form of integrity. Now, ataxia, everybody knows, is probably the most conspicuous or most common, but from my experience, I find that we tend to overdiagnose ataxia by mentioning it as ataxia. And majority of the cases is not really ataxia or not really singularly ataxia as a unitary factor leading to an imbalance, but there are more superimposed factors, superimposed movement disorders which lead to a compromised gain. Now, what do you mean by ataxia? So, in the dysfunction of cerebellar function, you see children with, they have dysregulation of any force, range, frequency, velocity, and rhythm of the movement, which leads to the loss of synergy and synchrony of the movement. So this is a fantastic concept. When you read, you realize that cerebellum is a fantastic organ that we have kind of discarded and made him a stepson or a stepbrother, stepsister for a very long time. So the synchrony movement is absent. The motor cortex is able to generate new function. The nigrostriatal-thalamic cortical pathway is able to plan the movement, plan the muscles to contract, the joint to move. But the cerebellum doesn't do the fine-tuning, the final tick to say, yes, let's go. You don't get a smooth movement that we tend to have. So, usually, ataxia comes in early, especially the central lesion. And then when you examine the patient, you tend to get dysmetria. So dysmetria is where the patient misses the target. Why the patient misses the target? So there's always this error in timing and sequence of the movement. Again, loss of synchrony. And then this series of successive movements which are supposed to be arranged one after another are not arranged one after another. They are arranged in a more discordant manner. So you get this impairment or this frequency between the rhythm and execution of the movement. So these movements at the end, at the resultant, become decomposed rather than a composed movement. That's where you get ataxia and dysmetria. Now if you see this video, thank God, what do you see? How many of you would think, it's a normal, I'm a pediatric neurologist, so I can recognize, but how many would think that this is normal child walking around? From the size of the child, those people who have seen children more, but kids, this child is around 2.5 to 3 years old. He's just running and I'm asking him to run, I'm taking a video of him. The mom is taking a video. What is obvious? There's no motor dysfunction. There's no weakness. He's able to run. There's no weakness. But if you look at the stance and the stride, and the positioning of the leg, you realize that it is discordant. Sometimes the legs go faster, sometimes the leg goes slower. Sometimes the leg goes slightly further front, sometimes the leg fails to go further front. So there's a discordant asynchrony between the right and the left leg placement, which leads to ataxia. And this is when he has improved. So if you compare the stride between this and this, you realize the synchrony in the second video compared to the slide, asynchrony in the first video. So this is where we get the disorders of movement. So if you look at this chart, I'm asking the child to sit up. I will stand hands in front horizontally, finger nose test. So one hand, she's able to touch the nose quite easily, although with certain difficulty. But the right hand, you'll see that there's a break in the synchrony of the movement. There's a break. So there's always this stop, start, stop, start. And the child is trying to do finger nose test. I'll play the video again, you can see it again. So look at the left hand. Smoother, more uniform, fluid. The right, there is a loss in the synchrony. It becomes less fluid. So this is the decomposition of the movement. So your movements are decomposed or fragmented to multiple movements, which gives you the picture of dysmetria and ataxia nivalis. Now, is this purely contributed by discoordination, purely contributed by loss of synchrony, or superimposed by some minute tremor, superimposed by mini myoclonus more over the distal region? It's sometimes difficult to differentiate, but as a movement disorders guy, I tend to try to differentiate because there are certain medications that use for certain conditions which you can't use for the other because it may exacerbate the other condition. Now, hypotonia. Hypotonia again refers to resistance to passive stress. I think most of you know. Now, why is that hypotonia a prominent component of cerebellar disease? It's because cerebellum kinds of maintains and regulates the tone which the upper motor neuron and the cerebellar cortex gives instruction to. So when I'm maintaining myself in a standing posture and I look normotonia, so cerebellum is working. Although cortex is giving the instruction, cerebellum is the one that is fine-tuning and coordinating all the movement. So when you have cerebellar disease, you can look for evidence of hypotonia. Sometimes hypotonia is exacerbated by ataxia, and sometimes hypotonia exacerbates ataxia itself because loss of postural muscle control and with loss of balance and coordination. Now, how does hypotonia manifest in oculomotor functioning, which we rarely pay attention to? How does it function? How does it affect or impact the voice, aphonia, not aphonia, but dysphonia? So one of the videos that I'm going to show you now. So asking you to do the finger nose test. You can see the decomposition of the movement, superimposed with mild tremor. But you notice that he has some difficulties in maintaining gaze at my video. He keeps closing his eyes. It is not voluntary. It is one of the clinical signs that you see in cerebellar diseases where, usually central and sometimes peripheral, where they are unable to maintain gaze that well, which is a primary contribution of hypotonia as an aspect of cerebellar. Now coming to dystonia, one of my favorite topics. So basically dystonia, for ages it has been known as a function of nigrostriatal pathway or network of nigrostriatal pathway. So when you have a dysfunction of basal ganglia or nigrostriatal pathway, you get dystonia one, especially if you affect putamen and thalamic. Basically recognized as clinically by repetitive abnormal movement and posture. The aspect that cerebellum may pay attention to dystonia is still in debate, but clinically such notion is gaining more attention because we have seen conditions where MRIs or structurally where the nigrostriatal pathway looks beautiful, but the cerebellum is the one that is affected, and patient comes in with dystonia. And you try hard to find clinical signs of any pathology which may be affecting the basal ganglia or nigrostriatal pathway, but you can't. Maybe towards later. So a few points to remember. Dystonia can affect any muscles because it's a control from the nigrostriatal pathway. The current research is focusing on how cerebellum physiologically affects, or rather modulates, the nigrostriatal pathway discharges to the brainstem, spinal cord, and also the peripheral nerve. And why these aspects is gaining more interest is that majority of the spinocerebellar ataxias and some of the hereditary spastic paraparesis that we see day in, day out in clinical practice, we find that they're primarily ataxic disorder, they're primarily cerebellar disorder, but you get dystonia as a clinical manifestation, as a primary manifestation. Why? So that's why the concept that dystonia itself is a network disorder which involves the cerebellum, including the nitrostriatal pathway, is emerging. So Fletcher et al. Is one of the persons who many years ago broached the topic, but the biased and very, what you call biased and very pompous movement disorder consultants tend to recognize this notion. So if you look at this video, this is a patient with spinocerebellar ataxia, but the more obvious clinical manifestation you see dystonia over the neck muscles. You know, she's got this neutral cortisol. If she doesn't, press her head against the chair or supports the head against the chair, what she'll get is a severe dystonia. Some elements of tremor, but majority dystonia. And she's got spinocerebellar ataxia. It's a trinucleotide repeat disease with autosomal dominant inheritance. Now we come to tremor. Majority of the tremor studies are for essential tremors and P in adults, not much in pediatrics, most in adults. So we get the information and we kind of parasite from their knowledge and from their experience, because you can't do these studies in children. Most of these studies by Mutroman et al. Or Timmer et al. Which are using EEG, MAG, and EMGs, study the cerebellar, they study the network which are involved in the generation and also maintenance of the tremor. So in one of the studies by Mutroman through EEG, they found that oscillating cerebellar networks were part of the underlying pathology or physiology. Then Timmer et al. Found MAG and EMG, which included cerebellum in one of the generators for tremor. And follow up the same tremor oscillating network involved the cerebellum. So cerebellum is indispensable. Now, for us neurologists, pediatric and adult, with this such notion and such study, we realize that for deep brain stimulation, if you try to stimulate STN or you try to stimulate big and walk in the thalamus and it doesn't work, then cerebellum is one of the sites that we can actually look at. Ambulation, okay? What happens in ambulation? What includes ambulation? What constitutes ambulation? The entire network of the cortex and basal ganglia, cerebellum, the spinal cord, the lower motor neuron functions in syncopy during ambulation. So if you have ataxia, then you can't walk that well. And stance and posture, usually children who have got ataxia, they're staggering, they're swaying, they've got difficulty to turn, they fall very frequently, they are unable to do a tandem walk, and the gait is never smooth. Same girl who has got spinocerebellar ataxia, duduk, bangun, duduk, tangan tegak, duduk, bangun, duduk. So there is this absence of smoothness in movement, asking the child to stand up, sit up, stand up, sit up. A simple movement as sitting up and standing up is absent. And asking the child to lift the hand, again the same test. Some children even have difficulties to sit when they have got tremor, ataxia, or what you call some mild myoclonus. And if you can see the synchrony or the coordination of the left and right hand movement, huge difference. When you ask her to walk, she's staggering, she's swaying, she's got difficulty to turn. And when she's turning, she always uses one leg to pivot herself. You know, to use as a fulcrum to pivot. So this is what happens in a child who has got cerebellar disease. It is not ataxia per se, but it's a constellation of every clinical impairment. Another child with oculomotor apraxia and ataxia. So broad-based gait, stride differs, absence of arm swing. So clinically, to a certain extent, some cerebellar disease may have certain suggestiveness for some elements of Parkinson. Right. Now I come to the slightly describing the movement disorders and disorders of movement. I will launch slightly to the two major illnesses that I see as a pediatric neurologist, which we should be primed to. One, immune-mediated disorders, which will present with cerebellar manifestation, and genetic cerebellar disorders. So, immune-mediated disorder is part of a bigger umbrella. I mean, it kind of launched like a rocket in 2007 since Professor Dalmau described this autoimmune encephalitis so far, where you find that there are certain antibodies which can disrupt this pathway, disrupt this network, disrupt the function of the cerebellum in the axonal ion channel level. So it may include, ataxia, the trigger known, which is gluten ataxia, post-infectious cerebellitis. You know the trigger, but you don't really know where the antibody is. Or you may find conditions where there are cerebellar disease with known anti-known antibodies, or certain primary autoimmune cerebellar conditions where no antibodies are known, but you have a gut feeling, you can bet your life on it that this is antibody associated because it works with immunomodulation. And of course, the bigger rubric of autoimmune encephalopathies or encephalitis where cerebellar disease may come in as one. So these are the whole list of diverse causes of commonly seen pediatric cerebellar autoimmune condition. Gluten ataxia, post-infectious cerebellitis, paraneoplastic cerebellar disease, which are more common in adults, except for one condition in children, opsoclonus, myoclonus, anti-GAD, we tend to see quite frequently. We can do the antibodies in America, even in Malaysia, and so forth. Now, autoimmune encephalitis, we clinicians should never miss. I think physiologists maybe come part of it, where children present in a subacute, acute manner with ataxia, tremor, or imbalance, loss of synchrony of the movement, incoordination. Some of them may become even obtunded without cerebellar dysfunction, cerebral dysfunction. So, it may present in a more larger manner other forms of motor disorders, encephalopathy, loss of memory, but cerebellar component is always quite common. Now, if you look at this list of antibodies that have been described and commonly seen in pediatric age group, MMDR, Casper, Group 1, Group 2, DPPX, IG-LON, GABA-A, GABA-B, majority of them may, or some of them may present cerebellar disease either in the primary or inside. So this slide I put up here to prime most clinicians, non-clinicians that subacute acute presentation of cerebellar condition with absence of tumor, you need to think of autoimmune condition because they have got good outcome. The outcome is so fantastic if they are treated, recognized and treated well. So this is a video of a child who has got autoimmune cerebellar disorder. Mild absence of coordination, more worsening. The stride and stance becomes impaired, the speed reduces, his response slower. You can see he's got a bit of truncal imbalance, could have been contributed by the cerebellar disease itself or the tremor. As the condition worsens, he becomes slower. Even slower, he can hardly walk, he can only sit. And if you compare the movements of the hand, you see the dysynchrony in mild bradykinesia, left and right hand. And this patient has got a more diffuse pathology, but there's always some form of discrepancy. As he moves further, loss of hypotonia, even his truncal posture, difficulty maintaining upward gaze or gaze, and even more further, loss of pursuit. He can't maintain and put smooth pursuit. More tremor, some dystonic posturing over the left hand. So if you look at the evolution of his cerebellar disease, from the beginning of loss of balance or impairment of balance, abnormality of the gait to hypotonia, admission of incorporating the hypotonia, absence of difficulty in gaze, and more some tremor and dystonia. So this is how certain cerebral conditions evolve. So if we keenly look at a child who has got certain progressive condition, neurodegenerative or genetic or even autoimmune encephalopathies, you will be able to clearly differentiate a certain phase where certain impairment of movement comes in. So it's for keen clinical eyes. And this child finally improves and went back home. Now, why, one of the slides that I urge to put myself, although it's probably not too relevant, why it's important for us to recognize cerebral disease early and then target the treatment early is because this thing called cerebral reserve. It's a concept that came up a few years ago. Some eminent physiologists and pathologists came up with this concept where if you treat early before the what it calls scarring and severe functional scarring and also structural scarring, the chances of the cerebellum to improve is almost complete. So they differentiate between functional reserve and also structural reserve. So if the right cerebellum becomes dysfunctional and the treatment is early, some transfer of function takes place and the left cerebellum can actually take over function of the right. And if in a single cerebellum, at zonal level, there's a dysfunction, impairment or damage or inflammation, early treatment can actually help the other axons to take over the function. So functional and structural, which is of paramount importance for us as clinicians, rather than dilly-dallying a certain diagnosis of treatment to catch diagnosis early and treat early if it is a treatment amenable. And then, one of the fast-growing diagnoses in cerebral disease, which is actually changing or studying the landscape of diagnosing cerebral disease with diamonds, is that is genomics, right? Many years ago, when I started as a pediatric neurologist, we didn't have access to whole exome, whole genome, or microarray. And majority of the times, we find a child with ataxia, we have nothing to do, and the options of medications are also so much more limited even now, except maybe amantadine and riluzole, but the options are very much limited. And without the power, or confidence of genetic diagnosis or genetic confirmation, we make a clinical diagnosis. Yes, it is an old era, which I sometimes smile at myself when I think about it. We just make a clinical diagnosis based on clinical science. But there are many fallacies here, in the sense, many of our cerebral diseases are genetic in origin, neurodegenerative conditions. They evolve. So our clinical diagnosis tends to evolve as new clinical science come in. So we have got difficulties trying to either fit in the clinical science into a diagnosis or keep changing the clinical diagnosis. That's one. Second, when the clinical science evolve, we change the diagnosis. So that's a upside down of the treatment. Oh, I was treating this child wrongly. And then we go back to another form of treatment because now the diagnosis has changed. But it's basically a neurodegenerative or evolving condition. Now with the advent of genomics, fantastic, we find a diagnosis, we know how it's going to evolve. So when the mom comes into you and sits and doctor, my child has been having this for the last, few months. Oh yes, it's expected, which I never used to say 15 years ago, but now, I'm empowered to say that. So I always differentiate into four main groups. Some of them are purely ataxic, spinal cerebral ataxia. Some of them are combined with other movement disorders, spasticity, myoclonus or dystonia, HSP variants, SEA variants. Some of them have got significant encephalopathy or cortical dysfunctions, the mitochondrial phenotypes, Golgi variants, and some of them are sadly neurodegenerative. Sometimes we can't do much about it. Ataxia telangiectasia, it's a fantastic teacher for pediatric movement disorders because the child has got cutaneous signs which evolve and become prominent when the child is 4 to 5 years old. The child also has got some cognitive impairment, which presents itself about 3 to 4 years old, and they may tend to present to you with early signs of recurrent pulmonary infection or so-called hyperactive airway disease, which are very fondly calling nowadays, and they come with movement disorders. They start out with mild imbalance, followed by hypotonia, added to hypotonia, then myoclonus, tremor, dystonia, and they neurodegenerate. Till date, we don't have a fantastic treatment for this, and a few of my research papers and with a group from Spain and also with the Netherlands, we are trying to explore what are the treatments that we should look at. So this is another fantastic concept. For example, now, most of you are very senior here, some much more senior than me. You realize that those days we used to use clonidine as an antihypertensive, right? And then some years ago, clonidine just lost favor because it's a useless antihypertensive, but you have got more beautiful, or rather well-lobbied. Now, you're looking at clonidine in a different perspective because it can help children with hyperactivity, ADHD. You're looking at it from an aspect of children with what you call basal ganglia disorder with dysautonomia, and you're looking at conditions where children with hyperkinetic movements, where risperidone and epilim or valproic acid, clonazepam doesn't work, you're looking at clonidine. So in our study and our research, we are brainstorming, trying to look at what are the old drugs that we can use back. So one of the drugs that keeps popping up is amantadine. And I've tried using amantadine on a few patients, and it's fantastic. But my notion is that it doesn't last long in neurodegenerative disorders. So this is a video of the child. Abnormality in tandem gait, severe hypotonia, and lots of tremor, but more of cervical, essential tremor line. As the child worsens, more tremor and dystonic posturing of the right hand, and incoordination. And this child has got lots of myoclonus. If you look at the sudden jerky movement of the neck, the dystonic movement of the hand, this is myoclonus. Both these kids are cousins and they have got ataxia telangiectasia because of consanguinity. And you have got certain neurodegenerative conditions which is sad to look at. Children regress, deteriorate, and they go to God, get discharged to God. They have nothing to do except prayers for them and counseling for the parents. So as this child started off, a bit of ataxic gait, wide straight stride, wide best. And now if you see the second video, the speed of the movement reduces, difficulty in turning, absence of hand movement, mild dystonic posturing, wheelchair bound, the third video, lots of tremor, dystonic posturing, and as the child worsens. And one of the most saddest part in some of these degenerative conditions is the brain is still functioning. They can smile, they can respond to you, they can laugh to you, you can bring them to a cafeteria, make them smile, buy for them something, cheat them, lie to them, make them laugh. But they regress and they die. Sad part, but keep them happy as long as they are alive and we are alive. So the diagnostic challenges in cerebellar disease is, one of the things that I wanted to pass and echo here would be, there's always an overlapping clinical science, overlapping pathophysiology. So it's important to look at it in a more holistic and broader manner rather than trying to focus only on cerebellar disease and ataxia itself. And there's always this discrepancy or disagreement between adult and pediatric movement disorders or pediatric neurologists because the manifestations are slightly different. Now, you are looking at pediatric age group where the brain has not been given an opportunity to mature and myelinate, and then at the same time the pathology starts to take place in tandem, in parallel. Whereas an adult brain where the brain is given a full, beautiful blossom to fully myelinated brain, and then get hit by the pathology. So the importance of genetic testing. And then one last aspect, opsoclonus myoclonus is a famous rare condition that we see children with primary cerebellar disorder who present with opsoclonus or oculomyoclonus. And they've got lots of peripheral, truncal, and appendicular myoclonus, prominent cerebellar ataxia, behavioral cerebellar dysfunction. So this is a post-infectious or paraneoplastic condition. So if you look at this video, so the child has got this very chaotic, erratic, multivectorial eye movement, to a certain extent that the speed is so fast, some would think actually it's tremulous eye movement. The way to differentiate between nystagmus and opsoclonus is video the child when the child is sleeping. Nystagmus disappears when the child is most of the time sleeping. Opsoclonus is there, irrespective of the brain sleeping or not. And you can see that there is a tumor. There is the tumor, carotid sheath. We never removed the tumor till now. She's about 14 years old, walking around with the tumor, but it's probably a dead tissue. So this is after she was treated with heavy immunotherapy, steroids, IVIG, rituximab. I rituxed her a few times, and she improved. So the beauty of recognizing cerebellar diseases, which is immune-mediated, is treating them early. If you treat them early, catch them early, hit them hard, they improve, normalize. And this child is 14 years old, walking around now. Okay, how to look at cerebellar conditions? Look at them as genetically, or look at them as how they present. Those conditions that present acutely or subacutely are usually acquired. They are either cerebrovascular in origin, what we call autoimmune origin, tumor-based, trauma, so forth. If they are more subacute, cerebrovascular, tumor in origin or autoimmune, but more towards genetic. If they are more subacute to chronic, they are evolving, then think of genetic conditions. So I just bruise through this slide. I think there's nothing much important. Just important, my last slide, important message to stand by, to go by. The phenomenology overlaps. So don't look at one phenomenology to make a diagnosis of cerebellar disorder. And the clinical science must be delineated clearly. Sorry. What gets involved first? How is the evolution of involvement? At what point the upper motor neuron, the cortex gets involved? At what point the cerebrum gets involved? That helps you to narrow down on the clinical diagnosis. And then clearly have a grasp of which is movement disorders and which is disorder of the movement, and where to go by and how to diagnose, what tests to do first. And analyze and objectify your evaluation rather than a what you call ghost chase. Always think of, subacute onset should be something more acquired. Don't forget about autoimmune process because they are very treatable, and it's a crime for us to miss those conditions. Neurodegenerative conditions are sad, very disheartening, but it's something we need to diagnose for the family and so forth. And progressive conditions, deserves a certain emergent attention from us so that you don't miss something that is treatable. So one of the words from Paul Gringard, which I always hold dear to myself, is if the brain was simple, then we would understand it, and it would be so simple that we actually cannot understand it. So the brain is never simple. And it's an evolution of learning from the time I became a registrar in Brompton, then I became a registrar in Mayo, New York. It's always learning. You tend to change your perspective. Like I mentioned earlier, I left physiology when I left medical school and I did my pediatrics in UK. But when I came to neurology, I realized that physiology was so important that I neglected it. Anyway, thank you very much. Just one slide. For those who are interested in pediatric movement disorders and so forth, I'm co-organizing with the AIMS New Delhi next month. It's a good, fantastic workshop, eminent speakers. So if you are interested or just pass the message, make some effort to come. Thank you very much.
Thank you, sir, for giving us an elaborate insight into the cerebellar functions and the excellent video clippings of the various types of cerebellar dysfunctions. So one question is from me. So as of now, they say the common cause for cerebellar ataxia in children or the pediatric age group is mostly of genetic component.
No, ma'am. The most common is still post-infectious cereballitis, autoimmune cereballitis. Either we find the antibodies or we don't recognize the antibodies. Sometimes antibodies takes months to yield positivity. And there's always this argument about you get the antibodies faster in the blood serum or you get the antibodies faster in the CSF. Different labs speak differently. For example, the NMDR, Professor Angela Vincent's lab in UK speaks differently from Dalmau's lab in US. So I find that probably doing both at the same time, if you have the opportunity, you may be having a higher shot at trying to get the antibodies. But irrespective of recognizing or not recognizing